Dr. Naman, you're there?
Yes, very good.
Can I start now?
Yeah, sure.
Okay. So good morning, everybody. I welcome you all to the GNB Clinical Anesthesia series, where we meet every Sunday. And today we have none other than Dr. Naman Shastri, who is a chief consultant and a cardiac anesthesiologist, as well as an intensivist at the Epic Hospital in Ahmedabad. He is the member of Research Committee of the American Society of Echocardiography, as well as the Dean of Echocardiography, National Association of Cardiac Anesthesia, a fellow of the American Society of Echocardiography. He's also the member of a review board of the Indian Journal of Pharmacology and member of the review board of the Annals of Cardiac Anesthesia. He also runs a cardiac anesthesia fellowship program, and of which he's the director at the Epic Hospital, Ahmedabad. In brief, I can just tell you, when we used to picture ourselves as doctors, we used to always think wearing a coat and having a stethoscope around our neck. Well, for Naman, you have to just picture him with a transesophageal echo or a plain thoracic echo probe around his neck. Naman is the word in echocardiography in, I think, in our country now. And very safely to say, I think he's one of the best persons to learn this from. So I thank Dr. Naman for spending the Sunday morning teaching us about echocardiography, and I welcome you to this program. You may now share your screen, Naman.
Am I audible? Am I audible?
Yes, you are audible, Naman.
Yeah. Thank you very much, Dr. Kalpana, for very nice work. But I really appreciate your efforts to treat and teach the DNB students, and that's very rarity nowadays in the private practice, and having so much passion for the teaching, and I appreciate for that. And thank you very much for inviting me for the DNB students. Rather than wasting much of the time, I would just straight away jump on the topic which was given to me by Dr. Kalpana, is understanding echocardiography reporting and clinical implications. I would just request all of you that if you have any questions, please moderate it, and we would be happy to take all of them. I have made a little change into the topic that along with the reading of echocardiography, it is very important that we correlate clinical, as far as that is one of the most important thing in our practice, whether we give anesthesia or not, but the pre-operative assessments, pre-anesthetic assessments, it's very important that first we start evaluating the patients and then correlate echocardiography. Very important says that the eye does not see when the mind does not know. So we have to understand what is happening, what is LV functions, what is valvular abnormalities, what is prosthetic valve, what is congenital anomalies. Here I would like to just brief more on the adult patients or one or two only congenital. So that's very important that we understand what cardiology mentioned to us when patient comes for the any non-cardiac surgery. Nowadays, in most of the Western countries, echocardiography is not only the part of and perspective of the cardiology, but in intraoperative, even the patient posted for non-cardiac surgeries, it has been practiced by most of the anesthesiologists to have the T probe with them, the capability of learning, capability of implementing the T images in perioperative period, because it is very safe, non-invasive, reproducibility and cost-effective is also there. Why cost-effective? Because what data we get out of the machine we use, and particularly when we talk about transthoracic, it is naturally, it's non-invasive and very easy to perform, provided you have a good training. After all of the thing is done, unless and until you are able to read the reporting, it is of no use. So believe me, it is not so difficult to read the report after getting the echo done. Now, as I said, in Western countries, there are so many centers there using transesophageal echocardiography in perioperative period in many of the conditions like hemodynamics, abnormalities, like when patient become hemodynamic unstable, unexpected hypotension, they they just push in the probe and just see whether the patient is hypovolemic, or wall motion anomalies, or valvular regurgitations, or cardiac tamponade. And it can also be useful to monitor perioperative hemodynamics conditions. After understanding the images in perioperative, we can suppose patient is hypovolemia. You can infuse a lot of volume and make the patient stable. So it can help us in guiding therapy. If patient is LV dysfunction, we can start certain inotropes or vasopressors. In that basis, we can alter our anesthesia management. And after all this thing, it is very important that we can report what we have seen in the echocardiography. Here, since the title is reporting, I will just constrain myself in the image, in the images and relevant reporting. So when we talk about echo, it is to be able to interpret findings from the images. Then we have to appreciate relative clinical values and integrate echocardiographic findings with the clinical examination. As I say to begin with, unless and until you evaluate the patients and then correlate echocardiography findings very well, then it will not be a useful of having the echo imaging and reporting understand very well. For example, if you just find a murmur and then look for the echo, if you say the patient has S3 gallop, you find patient has heart failure. If you see the patient has bilateral cracks with the basal of the lungs, and then you ask for the echo and then correlate clinically, or you ask for the echo reporting which patient had, then you should be able to correlate clinically. Suppose patient you have the patient pulse affect deficit, and you manage that patient's in perioperative period, but of course you should see that if patient has any echocardiography report before. If not done, we always ask for reporting when we are expecting atrial fibrillations like arrhythmias. So what guideline says in 2014 that when you should ask for the echo reporting. So clinically suspected moderate or greater degree of stenosis or regurgitation, and that is by the murmurs. So when you have any doubt on auscultation, you have a murmur. If you are not in a condition to appreciate whether systolic murmur or diastolic murmur, that's okay. But if you find some murmur, then if no prior echocardiography is done, or if echocardiography is done but not in short while, say for 3 months to 1 year, then we should always ask for it. Or if patients say that I have this problem 6 months back, but in since last 2 months, I'm getting some change in my clinical outcome, like breathlessness on exertions, or patient is feeling dyspnea, or giving any history of PND, you should ask for the echo or echo reporting. If patient has complaint of any dyspnea or breathlessness of unknown origin, patient doesn't have any history, then again you should ask for the echocardiography. Patient who had already heart failure, he has compromised ejection fractions, then also you should ask for the echocardiography if the recent echocardiography reporting is not done, and reassessment of LV function in clinical stable patients where the previously documented LV dysfunctions may be more than 6 months or 1 year, or patient has got new appearance of any symptoms. But yes, it is not recommended routinely. Recently in 2022, we had published preoperative assessment by the Indian Society of Anesthesiology. We have published guidelines. That guideline is freely available, and I am fortunate able to be part of it for making the guidelines. So in that, it is clearly mentioned when you should do the echocardiography or not. So when we jump on the echocardiography, there are the 4 places where they do echo. I will just not go very much into depth, as Dr. Kalpana has repeatedly reminded me that we should go very basic, because that is what your students. So there are the 4 important places where they put a probe in transthoracic. We will again stick to the transthoracic. So there are 4 different places like subcostal, apical, then we have the parasternal and the suprasternal. So this is suprasternal, this is apical, this is parasternal, and this is subcostal. There are different 4 ways where we are placing the probe. And this probe, why these 4 places? Because we can send the signals from 4 different places. Before again, I'll just brief 1 minute about what is echocardiography. So it is nothing but the probe which is sending the ultrasound signals, which goes to the body reflects from the moving or stable part, comes back to the probe, and then by the piezoelectric crystals, it makes a format the good imaging on the screen. That's what we are seeing. So basically, we are sending the ultrasound signal, which is not audible by our human ears. And then these signals are created into the pictorial format on the screen, and this is how we form the echocardiogram. So these are the images. These are the places, like as I said, this is the suprasternal aspects. This is the parasternal. This is apical, and this is subcostal. Just to evaluate and do the comprehensive examinations of transthoracic echocardiography, it is very important that we do all data by placing the probe in 4 different aspects. Many of the times we take the workshops for teaching the anesthesiologist how to do echo in preoperative and perioperative level, perioperative time, and it is very important that even they know this subcostal view. So these are the important view even every anesthesiologist should know. So again, this is suprasternal, parasternal, apical, and this is subcostal. And usually patient is kept on the right lateral positions, and we just hand and our echo machine lies on the left side. In Western countries, many of the people, they keep the machine the same side and they're turning the patient on the same side. But this is how right lateral position, left lateral position, because heart falls on the left side, comes near the chest wall. So the ultrasound imaging is very important, because it is very important that when ultrasound signal is sent to the body, there is no air or lung tissue in between, because then there will not be good reflection. So it should be like solid structures or liquid structure. So this is how we are placing the patient on left lateral position. So when in perioperative conditions, it is very important that the patient is on supine position, you may have difficulty in getting the good images. Sorry for trouble. I think I'll just restart it. So what is this parasternal windows? The parasternal windows means they put the probe right away at this level. And what images you get is like this. Now, when we say these images, parasternal, because we are putting the place just next to sternum, what we are getting is this is left atrium, this is left ventricle. From LA, the blood comes to the left ventricle, then LVOT, and it goes to the aorta. These two are mitral valve, of course, because this is LA and LV. This is anterior mitral leaflet, this is posterior mitral leaflet, and this is right ventricular outflow tract. So when they are placing the probe at the parasternal region, you get this view that is called plex view, because there is parasternal long axis. Then they just move the probe needle down.
Naman?
Yeah?
We cannot see your screen now.
You cannot see.
No, we are just seeing your desktop, but we are not seeing the slides. I'm sorry about this.
Yeah, again, I'll just check.
Yeah.
Can you see now?
Yes, now it's seen.
Okay. So when you, I'll just drag
Can you
down.
make it a full screen, please?
Yeah, okay. Can you see now?
Yeah, from the first slide we've started, but
Yeah.
it's
Yeah, okay. Can you see now?
very much.
Okay. Okay, so when they put a probe on the parasternal regions, this is the first image what they usually acquire. This view is called Plex view because it is called parasternal long axis view. Now they just take the turn probe little down, and then what they are looking into the aorta. So because this image will come again and again, so I'm not showing this. This is the, you can see the three cusp of the aorta. They still go further down. You can see the change of positions. And then what you are saying is you are cutting the probe at the level of left ventricular base of the left ventricle. What you are seeing here, this is a left ventricle cavity. This is the right ventricle. And here there are the two papillary muscles, and you will see the mitral leaflets. Now probe is going still further down. Why I'm showing is you have to keep on rotating your probe to see the different imaging, and this imaging is very important because that image shows complete left ventricle in the middle, from the left ventricle cutting at the mid cavity level. If you go further down, you can see again the apex. So this is how the parasternal long axis view is taken. What's happening? What's happening? Why it's taking down? Now, that was a parasternal view. Now, if you just take it the apical level, and this is very important view. This is left ventricle, this is right ventricle, this is left atrium, this is right atrium. So it is just a mirror image when you are you are standing in front of the mirror. This is called apical four-chamber view. And this view is also important. That will be explained later in our subsequent talks. Now, if we start with the echo reporting, the first and foremost thing we have to see that what is the ejection fraction. Like here you can see that when you do the echo reporting, when you read the echo reporting, you have to remember the sequence. Unless and until you remember the sequence, you may miss, because most of the days right now in many of the corporate institutions also, the sonographer, they do echo. They place it on the 4 lines echo reporting that ventricle function normal, patient has mild to moderate MR, mild AR, diastolic dysfunction grade 1, and patient can be operated. So you have no clues what is happening with the patient. So basically, if you don't miss anything, you should have to have the little sequence of everything. So first, we always look for the ejection fraction and systolic function. When you say the systolic functions, then we go for the hypertrophy of a chamber. Then we come to the wall motion anomalies. So here in the first 3, we just completely assess the left ventricle and the right ventricle. So first of all, look at the both ventricle, whether both ventricle thing has been mentioned or not, hypertrophy is mentioned or not, or wall motion anomalies is mentioned or not. After systolic function comes the diastolic functions, whether they have mentioned the grade or not. Most of the times, 80% patients you will find grade 1 diastolic dysfunction. And we are always confused. What is happening? Then comes the valves. They have to mention, if they say the valve, moderate or severe MR, what is the quantifications? When we take over the valve, what else of the heart structure is involved? That is also very important. If patient has mitral regurgitation, what is the pathology of mitral regurgitation? Whether because patient is coronary artery disease or valvular pathologies. Is there any congenital anomalies or ASD or BSD? Many of the times in the rapid echo imaging, they miss the septal defects. Very important thing is look at the PA pressures, particular patient having LV dysfunction, patient having the wall motion, patient having the valvular disease. PA pressure is estimation of PA pressures and right ventricle function is very important. So when we look at the echo reporting, along with the systolic functions, look for the valvular problems, look for the PA pressures, and look for the right ventricle functions. Every echo report should mention separately right ventricle function. If they are not mentioned, please ask right ventricle function, and always keep habit of correlating echo report with the ECG. That is always important. Now, when we talk about the wall motion anomalies, what is wall motion anomalies? Now, when we say, suppose this is the usually wall motion anomalies is measured in mid level of left ventricle, that is called mid papillary level. This is called because we are cutting left ventricle at the midpoint where the papillary muscles are here, and you can see that all the walls. Now, here when we say this triangle of echo imaging, this is what the probe lies here. So when the heart is near the probe, it is anterior structure. This part is anterior structure, and this part is always posterior structure. So when we see this image, it is image called short axis view of left ventricle, because in heart, we have cut the left ventricle in the slicing mode, and we see that two papillary muscles, this is anterior and this is posterior papillary muscles. Even we don't need to see that into the depth, but this is anterior part, this is posterior part, this part is right ventricle. So this is septum and this is lateral wall. So when they say anterior wall hypokinesia, usually we have hypokinesia at this level. When they say inferior wall hypokinesia, the hypokinesia is this level. When they say lateral wall, the lateral wall is at this time, and this is a septum. Now, why it is important? When we talk about anterior wall hypokinesia, means left ventricular descending artery is supplying anterior wall, and that is affected area. And when we say anterior wall hypokinesia, means, believe me, your 30% of a cardiac output is compromised. So when you have anterior wall hypokinesia, akinesia, means you have to understand that these patients' heart function is usually not normal. When you say the inferior wall affected, means still patient can have the preserved ejection fraction, because this inferior wall is supplied by right coronary artery, and it supply about 20 to maximum 25% of the heart, but 75% is still intact. But if you have combination of wall motion anomalies, means this heart function has to compromise. Now they say hypokinesia. What is hypokinesia? You can see that in a systolic phase, the myocardial wall becomes thickened. When this thickening is more than 30%, then we can say that the normal contractility. When the contractility is less than 30% but more than 10%, we can say hypokinesia. When there is no contractility, the left ventricle, the wall of left ventricle remains standstill. I will just show you in successive reporting the images. When it doesn't contract, it remains just standstill. It is akinesia. And when instead of contractile, it goes out with every systolic, it is called dyskinesia. What is important? If you have hypokinesia, it means that there is some myocardium preserved. So patient is having some endocardial MI, or patient have severe unstable angina, but still some myocardium is preserved, and patient is that myocardium is not dead. If you say akinesia, means there is a transmural MI, means complete myocardial thickness is lost. So in that case, if we have the anterior wall akinesia, means we have to, sometimes they mention anterior wall akinesia, so anterior wall scar. That means there is no myocardium. When there is no myocardium, whatever you give inotropes, inodilators, vasopressors, except of course not vasopressor, but any inotropes and inodilators, you will not have any contractility to that region because it is scar tissue, or we can say that there is continuous transmural MI, so there is no any myocardial wall preserved. So these wall never will contribute, even though you give inotropes or dilators, to the contractility. When you say dyskinesia, means this part is so bad, instead of contractile, it is bulging out, because this akinesia, this scarred part becomes so thinned out, so that rather than contractile, it is bulge out, like it is like ballooning out. So that is from all the aneurysm formations. So this is how we call it dyskinesia. So normokinesia means wall motion anomalies is not there, but when you say hypokinesia, means still myocardial preservation is there. Akinesia means loss of myocardium, and dyskinesia is significant loss of myocardium. Now they say M mode. What is M mode? M mode is like, this is the Planck's view. This is left atrium, left ventricle. This is mitral valve, LA, LV, then blood flows to the aorta. This is called aorta, and this is right ventricular outflow tract. This is called the Planck's view, and this is the first view. Usually, cardiologists they take, and when they say the ejection fraction, they more M mode ejection fraction. What is M mode? M mode is a motion mode. So it is a slicing of left ventricle at the tip of the mitral leaflet. So here they have cut a tip of mitral leaflets, and there is a motion picture in single dimension is appear on the screen. So we are not understanding anything beyond this side, beyond that side, but only the slicing, the small slice what you are seeing is the only this slicing is seen in the motion picture, and that is what it is known as M mode. So M mode is just slicing of the slicing of that tissue. So when you just go further, so this is what is a slicing. You can see the slicing, and this image is created. What is this image? Because this is cutting here, it has passed through this image, which is right ventricular outflow tract. So this is, first of all, it is passing to chest. So this image you get the chest, then it passes to the right ventricle cavity. So you get what this is right ventricle cavity. Then you go further. When you go further, this is left ventricle cavity. This is then you are getting the anterior septum. So this part is a septum part. Then you go to the left ventricle cavity. So here you get a left ventricle cavity, and then you get a posterior wall. So you are getting posterior wall. So that is the particularly slicing of left ventricle over the time. This is called the M mode. Usually M mode is not that reliable nowadays because we have much advanced echo imaging software available. But usually people would do this in the, like, if you talk about the very senior cardiologists practicing more than 30-40 years, they have learned and done echocardiography only on these images. So this is a systolic part, this is a diastolic part, because this is a so you can say heart is contracted, this is systole, then this is diastole, then systole, then diastole. So when it is enlarged, you can see the cavity is increased. So this is a diastolic phase, this is a systolic phase. So this is a diastole, and then it becomes systole. So when you say this is a diastole, then so you can see this is when it is enlarged, left ventricle two part, posterior wall and septums are going away with each other. So it is a diastole, and this is systole. So this is how you are measuring. Now the ejection fraction can be measured. Volume, if you measure this volume, that measure you the left ventricle volume. And usually we get images from that, but these images are not that reliable. Suppose this is a left ventricle dysfunction and we have taken a cross section from here. What you can see is this is whole septum, which is
Naman, can you excuse me? You're yet not on full screen, so we don't see your cursor most of the times. Is it possible to go back on full screen, please? I'm sorry to have bothering you like this.
No problem. Can you see? Can you see now?
Yeah, but now we are not seeing you on full screen. We are seeing you with your in a presenter view where you're seeing your next slide also, and the cursor movement is not seen.
Okay. Can you see it now?
No, we are back on the same thing. I can see your next slide as well.
Okay. Still you are seeing the same?
Yes.
So I'll just go down again, restart it. Can you see now?
Naman, we are able to see, but it is not on full screen. So your cursor is not being seen when you're pointing it out.
Okay, so what I'll do, I'll just again log in and then do it. Give me just 1 minute then.
Sure.
Can you allow me to share?
Can you allow me? Can you allow me? Can you allow me?
Hello.
Yes, Naman, I have made you the co-host again.
Can you allow me to share, please?
Yes, you are now the co-host. You may share, please. I think there are two laptops on, so there's a sound problem.
Just okay, I shut down. I use my second laptop.
Are you able to share now, Naman?
Can you see right now?
Yes, you need to put it in the slide view show. Full view
I'll
show.
just put it.
Yeah.
I mean, this was my table, my office table reporting. I mean, the desktop. Now I'm using my own MacBook. So, is it okay?
Yeah, much better.
Now, can you see this?
Yes, much better.
I'm sorry for all this thing.
No issue.
Yes. So I've kept one backup. So this is what we have gone through. Yeah. Is it audible? I am audible.
Yes, you are.
Hello.
Yes, Naman,
Yeah.
you're audible.
So if we say this is LV dysfunction, here you can see that I am passing the cursor is passed through the left ventricle, and you can see that this is what you can say complete dense white septum. That means you can see there is hardly any contractility of the septum. Is this is septum nearly severely hypokinetic, or we can say akinetic, and we can see that these are the two mitral leaflet because it is passing through the mitral leaflet. You can see this is big gap between this anterior mitral leaflet and the septum, which otherwise is not there. So this is called the excursion, but we will not go into detail. But here you can see this very thin, and you can see there is hardly any movement of the posterior wall. So this is LV dysfunction. What it gives an idea about, it gives an idea about cutting the section in that single slice. There is no two dimension, it is single dimensions. But nowadays people are not putting more effort into this because more advanced thing is available. Now something what is called is a Doppler. there are three ways of measuring the Doppler. One is continuous Doppler, one is pulse Doppler, one is color flow Doppler. Now, what is continuous Doppler? Continuous Doppler is when measured when the velocity is more than 1.5 to 2 meter per second. That particular every valvular structures we go with the continuous wave. So if you press it, you can press your cursor here and you can see what you are getting here. So this is what a RBCs which is flowing at the velocities of say 1 meter per second, or suppose we are passing through the tricuspid valve and this is a velocity of 2 meter per second. So here by the velocity they measure the gradient. So how the gradient is measured? They put a this Doppler, and from Doppler they measure the velocities, and these velocities they put it in the formula of 4v square and they measure the gradient. I will not go into the detail, but this continuous wave Doppler is called a CW, and that measures the gradient or high velocity. Now, second is a pulse wave Doppler. Usually, pulse wave Doppler is measured when there is a low velocity is less than 2.5 meter per second. Usually, the velocity is very less. Usually, these are measured at the level of low velocities area, and particularly that particular point of measurement. This is a flow of RBCs, and this is a measurement of the velocities. And from here also we can measure the gradient. Usually, when we measure the diastolic dysfunction, usually we put pulse wave Doppler at the tip of the leaflet, and we get this A and V waveform that will come later on. So this is also continuous wave for the high velocities, pulse wave for the low velocities, and then it comes the color flow Doppler. Color flow Doppler is used for measurement, like see the regurgitation. Here you can see this is left atrium, left ventricle, right atrium, right ventricle. These are the tricuspid regurgitation. See the blood flow is coming back. This is for TR. This is mitral valve. So this is blood flow is coming back. This is called MR. So these are TR, MR. So this color flow Dopplers gives an idea how the regurgitation is there, how much regurgitation is there. I will not go into detail, but this is just how they measure the regurgitation. So by putting the color flow metric. Now, if we start with the reporting, suppose these days I have kept all my reporting only. Suppose this is reports a biventricle normal function, normal size and shape. LV contract patient has hypertrophied left ventricle, no wall motion anomalies. Now remember the reporting I have said the sequence. First is LV functions comes, then hypertrophy comes, then wall motion anomalies comes, then our LV function is over. Then comes valve. You can see here all valves are normal. Then there is no MR, no AR, no TR, means no regurgitation of mitral, aortic or tricuspid, no pulmonary hypertensions, and patient has got significant normality. There is mildly elevated LA pressures and LVDP, no pericardial collections. So these shows a complete echocardiography of a normal left ventricle heart. You can see that, and if you see the images, visual images is like this. You can see very nice contractile thickness, more than 30%. Both here, this is a plex view, and you can see the mitral valve, and here this is aortic valve contractile very well. Right ventricle size is also normal. So this is how the valve. But what is missing here, though it was my reporting, what is missing here, I have not mentioned the heart rate and rhythm. It is very important that we see that what was the ECG, what was the heart rate at that particular moment. I'll just show you next. Now, again, this is the four-chamber view. This is left atrium, this is left ventricle, this is right atrium, right ventricle. This is called apical four-chamber view. You can see very nice contracted left ventricle. This is left atrium. So usually they see mainly three views: plex view, which was seen before. This is apical four-chamber view, and this is personal short axis view. Here you can see the distribution of all the coronary arteries, and you can see the wall motion thickness is all preserved, and we can say, yeah, it is all thickness is preserved and there is a wall motion anomaly. So when this patient comes to the anesthesia side, this patient is can be taken for surgery without any considerations. They put, like in that report it was mentioned,
no AR, no MR. You can see hardly any flow going in the plex view from LV to LA, hardly any flow. So this is not significant MR. And here also you can see, you can correlate these two views. So when we see the normal functions, see the sequences of finished LV function. If RV function is not mentioned, look at it RV functions. Then look at the hypertrophic, look at the diastolic functions, look at the VAR, look at the this has to be mentioned that I will show you. Now, this is an axiom of a case. Suppose this patient comes to you, mention significant dilated LV with significant globular hypokinesia, LV function is 20%. This 20% ejection fraction is only a visual image. This can be 10 to 15%. If I see images, I look at 20%, somebody may feel 15%, somebody may 25% because it is completely eyeballing. So in this case, anything less than 30% is significantly compromised. I will show you later on. You can see here then mentioned hypertrophy of left ventricle. This is say heart rate at say 70 beats per minute, globular hypokinesia, and most important thing they have mentioned LV desynchrony. Remember that whenever you see hypokinesia with desynchrony means you are losing 30 to 40% of a cardiac output because all the walls are not contractile in the desynchrony. And when you see desynchrony, when you see desynchrony means imaging that there cannot be normal LV functions. LV function has to compromise. How can LV function can be normal when the whole heart is contractile very well? In this case, heart walls are not contractile normal because they are not in synchrony. Ejection fraction has to compromise. So the echo looks like this. You can see that hardly any contractility. This is tricuspid right ventricle. You can see this. This is heart is not contractile in a same synchronic fashion. One is contractile, another is going outside, so it is like dancing left ventricle. You can see that ejection fraction is compromised, and this heart, you can see the right ventricle function is reduced, but not that compromised. We can say the RV function is still preserved, but rhythm there may be intermittent APCs with occasional VPCs. As I said, 70 beats per minute, there is intermittent VPCs or APCs. So when you see such imaging means you have to say that every such imaging modality, imaging like interpretations that reduces ejection fraction significantly. So when there is a VPCs, you will not have the good cardiac output. When you have the APCs, so for having a good cardiac output, atrium has to contractile, which preceded by the ventricle, followed by the ventricle. So atrial contract, mitral ventricle contract. So it should contract with the rhythm. That is a sinus rhythm. So when you have a sinus rhythm, then you say that okay, both contractility is preserved. In that case, when you are using inotropes or inodilators, you will have the great results. But if you have the desynchrony, if you have the arrhythmias, atrial fibrillations or flutter, you will not have the good results. So rate and rhythm is very important. RV function is equally important. Like in this case, RV function is good, is definitely compromised. So these patients, when you have biventricle dysfunction, you have to be very, very alert because right ventricle is giving preload to the left ventricle. So even LV is already bad. When the right ventricle is bad, no preload for the left ventricle. So these patients is very compromised, and regional anesthesia and to the extent general anesthesia is also a very, very high risk. Regional anesthesia is to be avoided unless and until it is must. Block kind of patients, block kind of management or to such patients. Now, if you put a biventricular dysfunction, like you put a M mode, you can see the septum is totally straight line. There is no systolic or diastolic waveform seen. So this is akinesia you can see. This is significant hypokinesia, and you can see this is big wall difference between septal wall and posterior wall. So left ventricle is enlarged. This is right ventricle. Again, I will not go into the M mode, and you also don't go into M mode because, but I'm just showing how the heart looks like when they are showing it. So when you see the LV function, what are the important points? Not is anything more than 50%. Mild LV dysfunction is where it is up to 40 to 45% ejection, up to the 40 to 45%, you can say it is a mild LV dysfunction. So anything above 40%, 40 to 45%, it is mild. still you don't need to manage anesthesia management significantly. Moderate LV dysfunction is 30 to anything up to the 30 to 40% is moderate. In such case, you should be very careful because there is, they mentioned 30% can be 25% because it is again eyeballing. So you have to see, you have to consider looking at all the volumes, all the chambers, valves, rhythm, everything. So anything less than 40% should raise your eyes, should raise your mind that you have to go much into detail. Then when you talk about severe LV dysfunction, it is less than 30%, means these patients are very high risk patients. So in such patient, you have to look for the valves because when ejection fraction goes down, heart enlarges, the walls have become leaking, so there are regurgitation of the walls, the chamber size enlarged. Look for the other pressure and look at the pulmonary pressures. So if patient has high PA pressures, if patient wall are leaking along with the dysfunctions, there are categories where regional anesthesia is not the choice. General anesthesia is preferable. Starting inodilators and everything is very important because patient has regurgitations, dilated heart. So you need to unload the heart by reducing the afterload. Now the question is, even we give regional anesthesia also reduces the afterload, but heart cannot compromise against the reduction of the afterload. So in such cases, you may have to start the noradrenaline or vasopressin. So all this thing is important, and look for the RV function is very important when you have the compromised left ventricle functions. Now from here we go to the wall motion anomalies. You see that the wall motion anomalies is normal. But if you say the anterior wall hypokinesia, you can see this is hardly any movement. Anterior wall hypokinesia, this is the anterior wall, this is the posterior wall. You can see the compare, and this segment is hardly moving at all, but this segment is so this anterior wall hypokinesia. Believe me, if you say the anterior wall hypokinesia, one thing is very sure that your ejection fraction is reduced by 30% at least, because anterior LAD supplies 30%, 30 to 40% of the muscles, 25 to 30% by the OM, and combinedly they supplies at least 70 to 75%, and only right coronary artery supplies about 20 to 25%. So if your anterior wall or LAD territory is hypokinetic, then you have to consider that you are compromising that very significant here. Now here there is only mild hypokinesia. We have to be careful to evaluate the mild hypokinesia in one region. So you can see that if you have only inferior wall hypokinesia, means RC is involved, then you can say, okay, I can manage this patient in all form of anesthesia. Remember that when you right coronary artery consists of these patients sometimes, because RCA supplies the conduction fibers. So these patients can have the first degree heart block or the second degree heart block. So you have to see that when they say the right coronary artery involved, right coronary artery means right ventricle part is involved or inferior wall involved, then you should also look for the coronary arteries. So when you look at the wall motion anomalies, as I said, what is hypokinesia and what is dyskinesia, most important thing is look at the anterior wall. If they say anterior wall hypokinesia, whatever the ejection fraction say, consider that it is 30% less than normal. 30% less than means if it is 60% ejection fraction, if we say 50% is normal, at least it is less than 35%. So 30% of total contractility is reduced if there is anterior wall involved. Inferior wall is acceptable. When you have akinesia of any territory, means you have to consider that again you have the loss that particular region. So when they mention anterior wall akinesia, means believe you that ejection fraction cannot be more than 30%, whatever they write it. Because this whole anterior territory means when there is akinesia, means transmural MI happen to the anterior wall, and then this anterior wall need not be contributing to the cardiac output. So you have to consider that there has to be at least 30% or less cardiac output for these patients. When you have dyskinesia, means you have to say that if you increase the contractility, there will be the further more dyskinesia, because it is instead of going in, it is going out. So this is loss of volume and this is development of aneurysm. So dyskinetic patient is very important, because whenever they say dyskinesia, chances of thrombus in that particular region is always there. As I said, right ventricle function is also important. Don't finish any report situations without looking for the right ventricle function. This is very nice right ventricle function in this is RA, this is RV, this is tricuspid valve. But when they have right ventricle function deteriorated, then like here you can see there's hardly right ventricle function. This part RA is stagnant, big. RV is stagnant, big. There are a lot of echo contrast. This is like when you say that they write echo contrast, when they say spontaneous echo contrast means you have to believe that that walls are not contracted, so blood is become stagnant. So this is significant right ventricle dysfunction. And when you see this kind of right dysfunction means you have to believe that these patients are going to give you trouble. When you say RV dysfunction, check two important aspects. What is a left ventricle function? If patient has also left ventricle functions, regional anesthesia is going to give you a lot of trouble unless you give high anodilators and vasopressors. If your RV dysfunction is compromised, dobutamine, milrinone are the drug of choice to increase the contractility, and if required, adrenaline. So when you have right ventricle dysfunction, second important thing you have to see is PA pressures. If patient has RV dysfunction and high PA pressure means, believe me, RV is already dysfunction, but blood flows to the right ventricle, goes to the pulmonary artery. If PA pressure is very high, RV will also have more difficulty in pushing the blood to the pulmonary circulations. So when you have a combination of RV dysfunction with the high pulmonary pressures, means heart is not going to give any support from the right ventricle. So when you have right ventricle, look at the LV functions. When you have right ventricle, look at the PA pressures, and this is very important. Now then comes the diastolic functions. Now you see how we measure diastolic function. We put a cursor right on the level of the tip of the mitral leaflet, and then we press a pulse wave Doppler, and what we get, these images. This is images. This is called E wave, and this is called E wave, and this is called A wave. E wave is early filling. A wave is atrial contractility. Like we know in diastolic phase, there are four phases. First phase is IVRT, means what happens when diastolic start. Both valves are closed, but now diastole means heart has contractile like squeezing. When systole is over, it starts dilating. But when it starts dilating, it unwill, and then still valves are not open, but it has started producing ventricular cavities. So that is called IVRT, isovolumic relaxation time. Hello? Hello? Anything you want to say?
No, continue. Naman, your voice is a little cracking for some reason. I don't know whether you want to come near the speaker and talk.
Is it okay now?
Better.
Is it okay?
Yeah, better.
Okay, so I'll just use my iPad. To show it. Is that okay now?
Yeah, much better. It sounds much
Hello?
sounds much better now.
Is that okay?
As of now, it's sounding good, Naman.
Am I audible?
Yes.
Hello?
Yes, you are audible. Naman, you are audible.
Am I audible?
Yeah, you're audible now.
So here you can see that the pulse wave is kept here at the leaflet tip. Now here you can see that once you press it here, keep it here, and there is a pulse wave. What image you get is the E and A wave image. And this is how completely diastolic function is based on this. So this is early filling of a diastolic. So after IVRT, means after the unsqueezing of the left ventricle, both valves are still closed. When negative pressure generates into the left ventricle cavity, this mitral valve opens. Once mitral valve opens, LA pushes the blood with a high force into the left ventricle, and that's what we get E wave. So once we get E wave, that is called early filling. Now what will happen after having the gush of blood from the LA to LV? Time will come when LA pressure and LV pressure become equalized. So both the pressure is equal, and that is called the phase of diastasis. Once the diastasis phase over, then now since both the pressures are equal, how the blood will come from LA to LV? Then atria has to contract further to push the blood down, and that's what we get A wave. So this is E wave is early filling, and A wave is atrial contractions. Now, when we look at this E wave, which is bigger than A wave, it means that the diastolic function is normal, because if A wave is small, that means that atria has not to fight a lot of pressures against the left ventricle. So the atrial E wave is smaller and E wave is bigger. So what you get in this diastolic functions, the reporting is, usually we get this diastolic dysfunction in patient having the hypertrophied heart. All the patients, 100% patient beyond 50 years of age will have diastolic dysfunction grade 1, and grade 1 beyond 50 to 55 years of age is normal. Am I audible?
Yes, you are. Yes, you are.
Yeah. So any patients beyond 50 to 55 years of age, you read that patient has diastolic dysfunction grade 1, don't panic, this is a normal. 70 years of patients, diastolic grade 1 is normal. But if you have, so I will just show you what is grading. So these usually we get patient with a hypertensive heart, we will have the diastolic dysfunction. Now what is diastolic dysfunction? As I said, normally the E wave is bigger than A wave. So when you have E wave is bigger than A wave and the patient is not having any major history, no breathlessness, no any valvular problem, then believe me that this patient is normal diastolic bias. When patient has diastolic dysfunction grade 1, when they mention means E wave is smaller than A wave, means what will happen that now the pressures in the left ventricle has started developing, because it's the heart. What is diastolic dysfunction? Diastolic dysfunction means at a certain age or hypertensive patients or patient having aortic stenosis where ventricle has to fight a lot against the pressure, the wall thickness of the ventricle increases. What will happen that once thickness is increases, so the left ventricle becomes like a new balloon. Now if you go to the shop and buy a new balloon, the wall is thickened. So if you blow this new balloon, you will have to pressure more to inflate the balloon. So same thing happens with this thickened left ventricle, that you have to pressure high pressure to the left ventricle by the blood, by atrium, to push the blood. So what will happen once in grade 1, when diastole is starting and mitral valve is opening, the blood cannot go very gradually because there is already high pressure inside. So early filling will be less. So in that case, atria has to contract with high pressure. So in grade 1, E is small and A is 1. A is bigger. But when it increases diastolic dysfunctions, so it becomes again normal. So E becomes bigger, A becomes smaller. In further going down, E becomes further increases and E becomes further small. So you can see the A is hardly anything. So how to differentiate the normal versus the very high grade of diastolic dysfunction? So usually what will happen, if they mention E wave velocities and A wave velocities, if the E wave velocities is more than 2 times of A velocities, means it is bad. Usually the E velocities is less than 2 times of A wave when E wave is bigger than A wave. If E wave is smaller than A wave, then he is having grade 1. So when will you see E is bigger? Usually in reporting, they mention E is smaller than A, or they mention E is bigger than A. Then look at the velocities. If E is bigger than A, that is okay. But if the velocities is more than 2 times of velocities of A wave, then you should think this is something abnormal. Now, what this grading means, normal is normal, but when you have grade 1, forget it, it is still normal. But when you have E velocities more than 2 times, and when they say grade 2 or grade 3, these grade 2 patients, they need high blockers like high calcium channel blockers, high beta blockers. Their needs heart rate around 50 to 60. This patient, if you increases inotrope dilators, it increases adrenaline secretions, these patients produce tachycardia and their cardiac output will compromise. These patients cannot tolerate tachycardia. So you have to manage anesthesia management to maintain the heart rate. If you have the grade 3 patients, like E is more than 2.5 times of A wave, it means that this patient needs diuretics, this patient needs dehydration. So regional anesthesia is not good for grade 3 patients. Grade 2 patient, if you want to give vasopressor first, maintain the vascular tone, and then give regional anesthesia, because these patients will not be able to manage their vasodilatations. So when you see the diastolic dysfunction, normal means E and A wave is nearly the same, or little a is big, it's fine. E small than A is fine, but when it is more than 2.5 times, means you should consider that they need strict beta blocker, calcium channel blocker, or sometimes. And these patients complain, believe me, 30% of the ICU admission with the breathless says these patients will have diastolic dysfunction. Patient having a myocardial ischemia, 100% patient is having diastolic dysfunctions. So we have to think diastolic dysfunctions very, very importantly, not casually. Now, so the importance of grading is grading 1, you don't have to change the anesthesia techniques, but grade 2 and grade 3, you should be very careful. So always see habit of looking E velocities and A velocities. If A velocity is too small or E velocity is more than 2.5 times of the A velocities, means you have to be very careful. So this is one of the pulse wave I had of the grade 3 velocity. You can see the E is such a big, A is very small. You can see E is very big, A is very small. So this patient, see, you can see this regurgitation also. This regurgitation is called the diastolic MI because high LVDP. I will not go into detail, but this you can see this E wave is such a small, E wave is such a big, and here they you get a velocity. See here they have pressed the cursor here, you get the velocities here. If you put the cursor here, it hardly 0.1 to 0.2, so you can see more than 2.5, 3 times. Now from systolic, diastolic wall motion, then we go to the walls. Many of the times you say the mild mitral regurgitations, and this is a severe mitral regurgitations. Mild mitral regurgitations, when you 30% patient will have mild MR without any pathology, so you may not take it seriously. Mild MR is there in 30% patient. In female beyond 50 years of age, it is usually there. You can see this is all the mild MR and you don't have to do anything with the mild MR. But when you have the moderate to severe MR, again you should think it has to be pathology. There cannot be moderate or severe MR physiologically or non-pathological. So usually when you have the severe MR, you have to see the pathology, what pathology lies. So in mild MR, you will not have any murmur, but in severe MR, you will have murmur. Now, when you have a murmur, when you have severe MR, means this murmur is not chronic murmur. Otherwise, what will happen, or ischemic murmur, or heart is not dilated. What will happen when you have the MR, left ventricle will start dilating. When you have start dilatation of left ventricle, there will be start compensation of left ventricle. So once heart is significantly dilated, heart start dysfunction. When heart start dysfunction, it cannot produce very significant MR because of heart is dysfunction. It cannot produce good cardiac output, so no MR is produced. So remember that murmur is very important, but in severe MR, if you don't find the murmur, does not mean that there is no severe MR. Severe MR can be there without murmur also. So when you have a murmur, look at the pathology. These patients are more vulnerable to atrial fibrillations because their left atrium is dilated, left ventricle is dilated. This, when you have the regurgitant lesions, I know dilator is a better drug of choice than vasopressors. General anesthesia is preferable, but you can, if you pay, if hemodynamic stable, regional anesthesia with good hemodynamic monitoring, you can still give with mitral regurgitations. So here is a reporting, LA severely dilated, RV is normal size. Now the patient has got moderate MR, dilated mitral annulus, and subvalvular thickening, and patient has also mitral stenosis. So many patients, they have combined mitral stenosis and combined mitral regurgitations. And what adds further return? When you have combined pathologies, always look for the other valves. Aortic valve, mild AR, frigated. Tricuspid valve, moderate TR, still we have to consider, but there is a continuous atrial fibrillation during the study. So these patient is atrial fibrillations. When you have atrial fibrillations, your left ventricle cardiac output reduces by 30% because there is no support of a sinus atrial kicks. Beyond that, there is MS. So heart is hard, LV is hardly getting blood. Beyond that, there is MR. So most of the blood goes back. So when patient has atrial fibrillation with MS with MR, you cannot manage these patients with the regional anesthesia. If it is not an emergency, this patient can be subjected for the surgical treatment or cath intervention for such valve before taking this patient if it is not in urgency. Now here you can see that LA is dilated. There is severe mitral stenosis, and if you go further, you can see dilate, and these patient MS patient atrial fibrillations always look for the thrombus. Here it is mentioned or not, there is a large layer of LA clot mentioned here. You can see this. So patient has thrombus. Every echo where it is mentioned atrial fibrillations or flutter, always is there any thrombus? When it is thrombus, patient must be on any anticoagulation. So this history is very important to be taken. Atrial fibrillation, look for the available layer of clot or thrombus. Check the history of anticoagulations because this is very important. Now, when they have the severe degree of mitral valve disease, always look for the right side of the heart, right ventricle function, tricuspid regurgitations, or patient having the pulmonary hypertension. So here you can see that patient has got significant tricuspid regurgitation because it is completely, you can see it is completely backflow happening to the patients. Because of the severe MSMR, patient has got severe tricuspid regurgitation, and you are getting severe tricuspid regurgitation. That shows patient has severe pulmonary hypertension. So when you have mitral valve disease, advanced stage, moderate to severe, always look for the tricuspid valve on the right side because back pressure changes, and always look for the pulmonary pressures. That is very important. For that matter, any valve disease, look for the right ventricle and look for the PA pressure and look for the tricuspid valve. Very important. So in mitral valve disease, important is rate and rhythm. As I said, atrial fibrillation is very important because that reduces the cardiac output. Further MSMR further reduces the cardiac output. Grade of stenosis and regurgitation is very important. So nowadays, in recent guidelines, says any mitral valve less than 2 centimeter is significant, not 1.51 centimeter. So in perioperative period, and if valve is any valve area less than 2 centimeters square is very important. You need to be very careful in such case. Less than 1.5 is very severe, and less than 1 is critical. Not like before that 1.5 is moderate and then it is 1 is severe and 0.5 is critical. No, physiological, these are the critical valve. Severity is less than 2 centimeters square, anything beyond that. And in such patient, when they are the fixed cardiac output, when stenosis is there, they cannot manage with the regional anesthesia very well. Grade of stenosis, look at the LA thrombus. Always look for the right side for the right ventricular dysfunction and pulmonary pressures. Look for the other valves. So dictum is when one valve is involved, always look for the other valves. And very important thing is when you look at the stenosis, it is a gradient which is important. It is not the peak gradient. Now, what is a gradient? I'll just tell you later on. Any gradient more than 8 millimeter of mercury in a mitral valve disease, mean gradient. Don't think peak gradient. They have to mention mean gradient, which is more than 8 in mitral valve, whether it is mitral valve or mitral valve prosthesis. Mean more than 8 for the mitral. Remember that. Mean more than 8 for mitral. If it is more than that, it is significantly physiological compromise. So this patient can give you a trouble in post-operatively. From here, this is the apical view to look at the aortic valve. This is an aortic valve gradient. What you are saying, this is an aortic valve. LA, then you can see here, I'll just show you again. So this is left atrium, left ventricle, then blood flows to the aorta. This is aortic valve, and this is aorta, and this is right ventricle side. And you can see the aortic valve. Then you can see the gradient here. What it is seeing, the maximum is 60% and 30%. So what is it? They have placed a continuous wave Doppler here because high velocity is there, and then they have traced the. This is called VTI, but I will not go into this into depth. But this is how they trace the Doppler, because the flow is going this direction. So they are tracing the Doppler, and this Doppler shows the gradient, and this gradient they show the mean gradient of 33 millimeter of mercury, and these are considered to be the significantly aortic stenosis. Now, sometimes you get any gradient beyond 30 millimeter of mercury mean is considered a significant gradient for aortic valve. For mitral valve, 8, for aortic valve, 30, because this gradient can give you physiological problem. So these patients, any gradient, mean gradient more than 30, you should think that these patients, once hypotension will occur, this patient will not be supported by the inotropics, inodilators, adrenaline, because there is a fixed orifice. In such cases, to maintain the pressures, you need noradrenaline. So regional anesthesia in more than this gradient is not the best idea. If you have to give it, give epidural, give noradrenaline, maintain mean pressures, and then start surgery, not before that. Sometimes you have the bicuspid aortic valve. So in bicuspid aortic valve, it is not necessary that your bicuspid aortic valve always show the gradient and regurgitation. Sometimes it is normal, but when you see the bicuspid aortic valve, this is how it looks. Bicuspid aortic valve, like usually this bicuspid aortic valve is showing more regurgitation than the stenosis. In older age group, it is more regurgitation in the all the stenosis. In the younger population, it is more regurgitations. So this is in a younger population. You can see the bicuspid, instead of 3 cusps, you can see only 2 cusps there. So this is what it is called a bicuspid aortic valve. Now bicuspid aortic valve, look at the AR and AS. If it is mild AS, mild AR, you manage patients routinely. You don't have to worry about anything. But if you have a significant aortic regurgitations, you should be careful. Now, from one note, bicuspid aortic valve is a pathology of aorta, not the heart. So patient can have the dilatation of aorta. So it is a congenital aortic deformities, not a left ventricular deformities. But again, I will not go into the detail about this. So in such cases, like in this case, we have traced a gradient, and gradient shows 58 peak, and the mean is 32, means this is an important aspect. Now, work is not over. Very important, when you see aortic valve disease, always look for their LV functions, because if the gradient is say 20, but LV function is only 30% or 20%, it means that heart is not contractile enough to produce a gradient. So if patient has LV dysfunction and having a gradient of 20, it is dangerous, because LV dysfunction is there, heart cannot pump adequately to generate a gradient, and patient has aortic valve stenosis, and patient cannot generate cardiac output. So when you have aortic stenosis, always look for the what is ejection fraction, whether heart is capable of generating gradient or not. Second thing is, if you have a high gradient, say 40-50 mean, usually you have to consider the LV function is not that bad, otherwise it cannot generate gradient. So anyway, when you say aortic valve gradient, always look for the LV function. If LV dysfunction is there, Do not estimate aortic gradient. Be careful in that. You will have the significant chamber hypertrophy, and this patient has got high tendency to get into atrial fibrillations. Third thing is, as I said, gradient in relation to the LV function is important. If these patients have aortic pathology and if their RV function is bad, remember that the mitral valve disease is always there, because they complete the channel from aorta, they reflect pressure on the mitral valve, it goes to the lungs, pulmonary circulations, it comes back to the right ventricle side, then RA side. So whenever you say any valve, look on the right side, that should be the dictum on the right side, right ventricle function, TR and PA pressures, all these three has to be seen. So mean more than 24, otherwise is mild stenosis, more than 30 is moderate stenosis, more than 40 is significant, but any gradient more than 30 in the aortic valve is physiological going to give you a problem. Many of the times you have a combined lesions, like they say mild to moderate MR, mild to moderate AR. They say mild AS, mild MS, mild AS, MS AR. These combined pathologies is most of the doctors or sonographers, they are not giving priority and they are not giving any good echo data which suggests us what is the status. But very important thing is, when you have the combined lesion, their pulmonary pressure has to be high, right ventricle has to dysfunctions, and when they have multiple involvement of a valve, that right ventricle function is more chances to be compromised cardiac output, and these patients usually have the atrial fibrillations or patient have any block patterns. So these patients, when you have a combined lesions, they patient can also have the multi-organ dysfunctions like right ventricle dysfunction signs, liver enlarged, ascites, low urine output, creatinine clearance is not good. So when you have a combined lesions, these patients should be kept into the high risk categories without any doubt. So liver and renal function is also involved in such cases, and these patients are in very high categories. Like when you have the patient with MR, AR, and you can see LV dysfunction, these patients are so combined lesions with LV dysfunctions. So already LV function is compromised. Most of the leaking valve gives LV dilatations. So these again, when you have a combined lesions with LV dysfunction, these are not the patients for the regional anesthesia for sure. You can see here, the same patient has MR, TR, AR, and LV dysfunction. This is a real case scenario of last week only. Then we had done the synchronized what is called a CRTD, continuous resynchronous therapy of this patient, and this patient is stable, because in these cases cardiac surgery even is not when these are the patients for the heart transplants. So like day after tomorrow, I'm going to do the live management of a patient being operated at kidney hospital. The patient is subjected to the heart transplant, but the patient has a kidney stones and they have to operate first for the kidney stones. So I'm going to manage that patient live from my hospital to other hospital. So now you may get such patients, because in heart transplant they have a rule to clear all the system before they come for the surgery. So this patient may come to you. So these are the very high risk candidate, and that management is totally different. This patient needs, I know, that complete good advanced hemodynamic monitoring, good CVP monitoring, arterial monitoring, I know dilators, I know tropes, vasopressors, everything in place with the intensive care management. Now the last wall is tricuspid regurgitation. You can here see the TR. RV function is okay, but patient has TR. TR means when you have TR, that reflects pulmonary pressures because they are the back pressures. So TR is an indicative marker of RV functions and PA pressures. So when you have a TR, always check what is a PA pressure. So when you say right ventricle side, you have to see only three things: RV functions, tricuspid regurgitations, and PR and PA pressures. All the three things. So TR is TR. Through the TR only, by placing the continuous wave, we measure the PA pressures, and the if patient has got TR, always look for the PA pressure. So in this patient had a PA pressure of 65 millimeter mercury. This patient has PA pressure was 40 millimeter mercury. Any PA pressures of more than 35 millimeter mercury is not normal. If patient has high PA pressure with normal right ventricle functions, still you can manage well. But PA pressure with RV dysfunctions are the worst patients to be managed. So from here, hello, is it anybody wants to say anything?
No, I had to just mute some people. Thank you.
Yeah. Okay, so these are the very high risk patients. So these are the patients who needs double wall replacements with severe LV dysfunction. But when they come to you for the surgery, preferably general anesthesia, preferably these patients needs good advanced hemodynamic monitoring and should be operated with the centers where they have intensive care unit facilities like tertiary centers. And like Dr. Kalpana Shah, like being a good friend, I know her. Like she's managing cardiac anesthesia as well as sometimes non-cardiac anesthesia also. So these are the people who can help you in perioperative management for such cases very well. I won't go with it further in this thing. So when you have all the for all the valve cases, you have to first see the anticoagulants, because these patients, when they have atrial fibrillation, look at the history of anticoagulants. Were you taking certain medications? If they have, when did they stop? What was the last PTINR? This is very important because physician may start on this. What is a stroke? Have you had this stroke? Because these patients, they have the tendency to throw the strokes when they have the atrial fibrillation. You should see that. Whether they have been taking echo report regularly. If I would say in all valve cases, if it is not done in previously 3 months, they should be repeated again. Should be done by the cardiologist. They are on diuretics. Look at the electrolyte imbalance, whether they are in hypokalemia or sodium imbalance. Hyponatremia, hypokalemia is very common. They have the bleeding tendency, because like you can ask the menstrual histories in female, because they are taking anticoagulants. So these patients and their liver is abnormal pathology may be there because of the chronic congestions. They have the bleeding tendencies. You should always see the bedside pulmonary function test, because this patient can have the low tidal volume. So I always request my colleagues to check the bedside pulmonary function test for us such cases, and look at the severity of the valve. When you have combined lesions, mitral valve has to be bad valve out of all, because the disease pathology starts from usually from the mitral valve. So look at into all this thing. Pulmonary pressures, anything more than 35 to 40 is significantly elevated. 35 more than that, it is PA pressure elevated. More than 40 millimeter mercury is very high. And they sometimes mention in terms of pulmonary artery systolic pressure, estimated right ventricle systolic pressure, or PA pressure, anything they mention like this. So anything more than 40 is significant. Now, prosthetic valves, there are two kinds of the valves available. One is bioprosthetic valves, another is mechanical valve. In bioprosthetic valve, you will not hear any clicks, no clicks. So patient don't ask the clicks to this valve, and usually this valve is placed in a patient either in a childbearing age or in the old age beyond 65 years of age. So usually these patients and their valve is difficult to see on X-ray also. So, but the problem with these valves is they last only for a few years, 8 to 10 years. So if you find this, and always when you have the prosthetic valve, always ask them that please show me your history, please show me your operative summary. That is very important. So which valve was placed, it is important. If it is a bioprosthetic valve in older age group, if they have crossed 10 years, then always ask for the on-site echo, or always, because beyond 10 years, chances of degeneration valves are very high. So always ask this if it is beyond 10 years. These patients are usually not on anticoagulants, so you don't have to worry about that. But in case of mechanical valve, these valve placed in any of the age in younger age group, they have the history of clicking. So always ask, is the clicking is the same as before, reducing? So they sometimes come with complaint like day before yesterday, like in our case scenario, I only thrombolize all patient after doing echo. So patient typically tell us the history that my valve clicking is not, I cannot listen my clicking since last 2 to 3 days. And then we find the valve to be thrombus. So these are the, so when you have the mechanical valve, many of the time centric valve is not seen on the X-ray chest, or not necessary that all valves are seen on the X-ray chest. So don't rely upon the XLHs. So presence of, so but they always on anticoagulants and they always have some clicks. We are doing one study of the one valve which are not bioprosthetic, but they don't require mechanical, anticoagulants. That will be later on, will come in some of the meeting again. So these are the kinds of the mechanical processes available. This is called bi-leaflet prosthesis. This is called the single leaflet prosthesis, and this is called ball and cage. Now these valves start adverse ball and cage valve is not available now. They are stopped. But believe me, this is one of the best valve where still I am saying following after 40 years, 35 years, this valve is still working very well. This patient is bi-leaflet valve and this patient will have the single leaflet valve, single leaflet. This is how they mention it. So now what is the reporting? Biventricle normal function with normal size and shape, concentric hypertrophy, thickened walls, ejection fraction normal. So this line completes our LV function. Patient second comes a rate, atrial fibrillation with a low ventricular rate. So this is very important. When you have already atrial fibrillations, atrial kick is not there, and the heart and all cardiac output depends upon the ventricle. And when their heart rate is less than 50, then what is the use of cardiac output? There is no cardiac output. So these patients are very bad patients. So that is why you can see here the rate. You can see the hardly any rate, and the patient has atrial fibrillations. And single tilting disc type of prosthetic mitral valve positions. Normal functioning valve with a gradient of peak gradient of 7, mean gradient of something. This is a printing mistake. It should be 70. No paravalvular leak. So when you see such patient, I'll just show you the second image. So if you say the such repeat, look at the yes, I have placed the underline, so that is something important. Here it is mentioned single tilting disc type of metallic prosthesis, but what look at the mean gradient which is 30. Now if they say a single tilting disc type of the mitral valve, and then you can see that they are seeing this one tilting disc is not possible, because the mean gradient is 30. It means that valve has to be closed, has to be thrombus, then they cannot see the single tilting disc of mitral valve. So what it would have happened, there are dual leaflets or double leaflet, bi-leaflet disc, but one leaflet is closed, only one leaflet they could see, and that is a gradient is producing. So always remember that, don't look at the leaflet, what they have single leaflet or bi-leaflet, look at the main gradient. In mitral valve, if the mean gradient is more than 10, whatever they mention, it is significantly stenosis or prosthetic valve dysfunction, and you should be very careful. Patients is double valve, single tilting disc, metallic prosthesis, but paravalvular, there is no paravalvular leak. Again, you can see the dilating ascending aorta. The gradient what they have mentioned is dilated ascending aorta, diameter is big. They have not mentioned, yeah, see, they have not mentioned the valve. This is myself. So I would not categorize these report as a valid report, because I am not seeing any gradient of aortic valve. So I would suggest you should report this again. So then I have make a circular signal here, and I have mentioned I have written the gradient here, which is a 12. But in reporting, I have not mentioned. So I have particularly produce a rate line symbol here that it is a 12 millimeter gradient. Mean gradient of 12 in aortic valve is normal. So again, this is very interesting report. I have placed it. They have not mentioned in the reporting, but look at the chart. There it is a mean gradient of aortic valve here mentioned. It is a 12, means yes, it is a normal functioning aortic valve. So aortic valve is okay. But here the mitral valve gradients, if it is 30, it is not a normal. So this is again a double valve prosthesis. Now suppose this patient comes to you, you cannot see the valve leaflet at all. You can see this is completely calcifications valve, and if you put a cursor, your gradient is 29 by mean gradient is 19. Anything beyond 10 is significant, and this patient has significant mitral valve disease. So this patient comes with acute bedrest conditions. They have invariably liver function damage because sudden back pressure on the liver. So this patient mean gradient is more than 10, means you should more than 8, believe me, more than 8. Then these patients are not the best patients for any anesthesia. If it is not an emergency, you can suggest. Suppose this patient would have been having the degenerative valve disease. You can suggest this is a high gradient. Patient has degenerative valve. Degeneration has happened to the bileaflet valve, which is a biological valve. You can correct the valve and then come. Nowadays, there is a valve in valve is possible. If patient is financially capable, this patient can be subjected valve in valve, and then this patient can be subjected for the non-cardiac surgery. If it is an emergency surgery, then we can consider this as a high-risk patients. Never think that these patients will tolerate regional anesthesia at all. This is the patient, the same patient. You can see this is totally leaflet contractility is not seen at all. Okay, so you can see here in there is only one stick of color is passing to the mitral valve, and so this is a valve process dysfunction. So here the reporting is bileaflet metallic prosthesis, anterior leaflet is partially fixed and posterior leaflet is freely open. No mitral valve prosthetic gradient is seen. So this is the patient, this previous patient I have done the thrombolysis, and this is a post-thrombolysis result that out of 2 leaflet, 1 leaflet is still restricted, and what was their mitral valve gradient is 6. So their mitral mean gradient has come down to 6, still one leaflet is stuck, but patient is still managed medically. Rest of the thing is fine. So this is how you can see here some movement of the artifact is seen here, which was not seen before. So this is how you can see, look at the prosthetic gradients. This is the same patient after thrombolysis. The gradient has come down from the 29 has come down to the 6 after the thrombolysis. Now this is again for the aortic valve DVR patients. You can see that after thrombolysis, you can see the color flow is established. You can see the movement of the leaflet. One leaflet is which is not seen otherwise. This is a bileaflet metallic prosthesis. Only one leaflet is seen. So and left ventricle contractility is seen. So what is important is in a case of metallic prosthesis, look at the gradient, look at the anticoagulant status, look at the rate and rhythm. Most important, when the surgery was done, whether it was biological valve or which was mechanical valve. If a mechanical valve, look for the anticoagulant histories. If a biological valve, look at the history of the placement. If any prosthetic valve is there, you should have the echo in last 3 months. If patient has recently presented with a breathlessness, then even the echo done 10 days before, if breathlessness is a recent origin, always repeat the history. This is what you are seeing is so valve type, clicking sound, rate and rhythm. Look at the atrial fibrillations. Ask for the regular follow-up. Was it done or not? History of anticoagulation, history of stroke, recent echocardiography, fever. History of fever is very important. Many of those patients may present with the vegetations. So patients like you are draining one patient for the abdominal sepsis or the orthopedic and you are doing deep debridement. Patient having a prosthetic valve, this patient can have the vegetations. So history of fever is there. Always check for the vegetations for such patients. So again, as I said, mean gradient of aortic valve and mean gradient of femoral valve. I will not go into the HOCM. The last few slides for the atrial septal defect. This is what is atrial septal defect. You can see is there is a left atrium, left ventricle, right atrium, right ventricle. RA is dilated. You have the size of ASD. You can see the flow from the left to the right. So this is a left to right shunt. So whenever you have ASD, It usually can be managed normally the way you manage, provided look at, so I'll tell you only simple. Flow will be left to right. There will be load on the right side. When there is a load of the right side, always look for the right ventricle function. When you look for the right ventricle function, third important thing what you see is TR and PA pressures. When you have ASD with high TR or when you have VSD with PA pressures more than 50, these patients are high risk patients. This patient can give you a trouble because ASD patients high PA pressure is not acceptable because they are low pressure jet. It is only volume load and producing PA pressure. If patient has a VSD and patient has high PA pressure is still acceptable. There is a VSD pressure which is high flow going to the lungs, but atrial septal defect with high PA pressures, particular patient comes in older age groups are very bad patients for the management. So when you have a patient with a ASD in a longer age, in the older age group, look at the RV function and PA pressures. Remember that in atrial septal defect, don't take very simple in the old populations. These patients can have the complete heart block, they have the rhythm problems, and these patients can have the significant RV dysfunction. So in patient with RV dysfunction, general anesthesia with dobutamine and inotropes are the better is a better combinations. Like here is the patient, and this is PA pressure of 72, normal systemic and pulmonary venous drainage. This is very important. When you have normal systemic and pulmonary venous drainage, means your congenital defect is not complex. Coronary sinus dilated is sometimes they mention, but this is not very important for anesthesia management. They mentioned two atria, but they have mentioned RAVO, that is right atrial volume overload. When they say the right atrial volume overload or right VVO, that means that this is volume overload, old age patients, long standing ASD, large 24 millimeter ostium sacchinum ASDs. So they have mentioned right ventricular volume overload also, and patient has severe pulmonary hypertension. So these patients are not the best patients for regional anesthesia. So now at the end, I have put 3 reporting just to show you how will you manage these patients in your perioperative management. Here it is mentioned severe ventricular dysfunction means high risk. Ejection fraction is only 15%, means these patients are probably subjected for the heart transplants. Beyond that, there is atrial fibrillations, ventricle rate is less than 100, globular hypokinesia, and LV desynchrony. If you mention ejection fraction or not, believe me, this is less than 15%. It has to be 10, 15, cannot be 20% even. This patient has got, probably this patient will have mitral regurgitation, even not mentioned because such a dilated heart, LV, such a dilated LA will produce MR. This patient will have a severe TR. But if patient has got high right ventricle dysfunction, you may not have high PA pressures because right ventricle dysfunction cannot push lot pressure volume, lot pressure to the lungs, so it may not produce PA pressures. But anyway, these patients biventricular dysfunction with rhythm disturbances, if possible, this patient is not suitable for any anesthesia, whether regional or general anesthesia. This patient is meant for the heart transplants. Again, this kind of the patient is same. This is another patient, LA dilated. LARV's patient has 40% normal, so mild LV dysfunction. Left ventricle volume size is 95 ml. Anything less than 140 is normal. It is all okay. Inferior wall is involved. Contractility and myocardium is preserved. Mild MR, that is all okay. Normal RV function is okay. But patient has got severe tricuspid regurgitations and patient has PA pressure is 75 millimeter mercury. If this patient comes, LV is okay. Inferior wall hypokinesia is okay. RV function is all okay, but only PA pressure is elevated. And this patient is subjected for, you suppose, intestinal obstruction, you need to give the laparoscopic surgery. So you are going to give laparoscopic surgery, you are going to inflate the lungs. High PA pressures can reduce the low cardiac output, particularly in Trendelenburg positions. But Still, these patients are not contraindicated for laparoscopic surgery, but you need go to advanced hemodynamic monitoring. What problem happens if patient develop pulmonary embolism in such patients? Then these patients will be worse patient to manage because this is already volume load, and then we are developing pulmonary embolism. So these are the worst patients. These patients anyway, severe TR, severe PH. If there is a good echocardiographer, he would tell you about the pulmonary vascular resistance. But if it is not there, but still this patient can be managed since his left ventricle function is normal and right ventricle function is normal. In patient has severe TR, with severe TR with the right ventricle function normal, you can manage medically and with a general anesthesia at all without any problems. So thanks for the time, though I had a lot of technical glitch, and I'm very sorry for that from my side, and sorry if it has gone too much exhaustive. And any questions further? Over to you, Dr. Kalpana.
Before I throw the questions to the audience, I think, Naman, you, in spite of all the technical glitches, you covered all the topics really well. And more so, you related it with patients coming in for any other surgery. You emphasized on the regional and general anesthesia part of it, which I'm sure were great take-home points. I thank you once again for spending the Sunday morning with us. And if there are any questions, please unmute yourself and do ask any questions to Dr. Naman Shastri.
Kalpana, I want a comment to make. Huh? Can I? This is Dr. Halbe.
Yes, madam, please.
Thank you very much, Dr. Shastri. It was excellent, and I don't know how to describe it. It was absolutely wonderful. And shall I tell you, each and every, I deal with geriatric patient in urology, and each and every patient you said is sort of, I felt I was very lucky to get away with it, because this patient come for prostate surgeries, and they do require regional anesthesia. So such time we are forced to give regional anesthesia to these patients, because that's the anesthesia for the prostatic surgery, and these are huge prostates, sometimes 100 plus grams. So what do I do in such case? Is there any way? Because see, it's usually procedure does not last more than an hour. So extensive hemodynamic monitoring.
Sorry for trouble. Yeah, please.
No, not at all.
Yeah, please.
Naman, I think you're frozen.
Got disconnected.
Yeah, I think he got disconnected.
I think he has some work, Kalpana. Because
I'm just trying to connect with him. Just give me a minute.
no, it's okay. That's
Sorry
all right.
about this. I'll just give you a bit. The thing is that I think he's in the hospital and the network at the hospisptal was not great. That's the reason.
Possible.
He's talking from
That was wonderful, and really thank you for arranging this. It was a great.
In spite of the technical glitches, and we couldn't hear him at some in between, but
no, nobody has left the seat and gone.
Yes,
everybody was there, remained with us rather.
Madam, just give me a minute. I'm calling him up.
Sure.
If not, we will. Yeah.
Sure. I just want to ask him, Kalpana, you can ask him in the sense, rather than wasting time, is that where do I stand? Suppose there is an event and somebody has to opine. He may opine that, oh, general anesthesia should have been there. And then where do I stand? Because it's a prostate. Our anesthesia says it should be usually done under regional for several reasons, whatever given, you know. So that is one thing. And secondly, he should tell his colleagues, every time cardiologist with 20% ejection fraction, if the patient comes, they say the patient should be done under regional anesthesia. I think he has come.
Sorry, madam. Actually, my phone was linked to my MacBook, so it got disconnected. Sorry, please go ahead, madam.
No. I was just saying with the whatever cases you mentioned, most of the time I face them, and I have been managing because these are all coming for prostate surgeries, and then that is the most indicated is regional. So I have been getting away with it. Now, suppose something there is an event, and then I have to face. Unfortunately, touch wood, it doesn't happen. Face a suit, a legal suit, or something, and somebody says that. Where do I stand in that case? Where do I stand? Because a person erudite like you will say, oh no, general anesthesia should have been given. And then I come in the trouble that way. That way I'm trying to say, how do I save myself? I will be taking care of patient whatever way. For
See,
myself, I'm asking.
Yeah, very, very true, madam. Very valid point in a present scenario. Basically, if you read the echo report and if you have doubt that these patients can give you trouble in particular given anesthesia. So like like in my hospital, we have 5 CTOT, but against in another corridor, we have 5 general OT. So many of the times I've been called for high risk cases when they are in trouble or they get arrhythmias or some problems. And once or twice it has happened that the patient had suddenly pulmonary embolism or collapse. And then they said they found that echo had some evidence of problems into it, then why we did not do this. So in such case, I always discuss with our anesthesia departments to better have everything on paper before managing in terms of the cardiac issues. If patient has shown any cardiac conditions, which is presumably having some impact in the perioperative management, like informed consent in terms of whatever the incidents can happen to such patients, like say for example, patients can have the pulmonary embolisms or patients can have atrial arrhythmias or low cardiac output syndromes. So anything can happen. So it is better to mention and explain on paper prior to surgery. Many of the time surgeons, they resist that please don't mention all this thing, otherwise patient will run out. But it is customary from our side and discuss with the surgeon that these are the problems. And what I suggest that whoever has done the echo, please call him personally. If you have any doubt, please call the guy who has done the echo that you have mentioned this and that particularly. What do you mean by this?
Okay.
He like many of the times when general, like I do the most of the non-cardiac surgery echo, I do it for them because they refer to me. And they call me that Dr. Naman, you have mentioned that patient has LV hypertrophy and diastolic dysfunction grade 2. What does that mean? So basically, see that it should be done by the cardiologist, not the sonographer. Number one. Second thing, if you have a doubt, you ask them, are there any possibilities of these patients getting into low cardiac output, like patient having atrial fibrillation with mitral stenosis?
Okay.
These patients can go into the low cardiac output. Many of the time, physicians, they say patient is fit for the surgery with a due risk. What is due risk? There is no definition of a due risk. The patient can be taken with a due risk. But if something goes wrong, so whoever has done the echocardiography, ask him to mention that if you have done the echocardiography, please mention that this patient has got chances of getting these in perioperative period. So I think that will support you in intraoperative lawsuits. Otherwise, I mean, I don't have more answer to this. Anybody else?
Dr. Naman, there is a question which says that what is the safe pulmonary artery pressure for a central neural axis blockade?
This is, as I said, more than 40, less than 40, 45 PA pressures. But again, I would say that don't stick to the PA pressures only. Like when you have a PA pressures only, there are two reasons. There can be the lungs per se is the only reasons. Like say patient has got some pulmonary embolism, or non-pulmonary embolism, or patient has got high PVR, for another patient has primary pulmonary hypertension, see the hearts are normal. So when you have isolated pulmonary hypertension, always find the cause, what could be the reason. Many of the times, patients in adult age group, when I think I'm getting echo.
Yes.
I'm getting my own echo.
Yeah, yeah.
Why should I get the echo? I don't know. My Zoom meeting is not there on any other platform. So what would happen that suppose patient present with a 60 PA pressure. Now look at whether this PA pressure is because of the lungs or because of the heart. Many of the times patients come with a primary pulmonary hypertension where the heart looks normal. Your heart looks normal, but patient has, these are the dangerous patients. But when patient has got mild and moderate TR, RE function is normal, and the patient has not any primary pulmonary hypertension, so I think you can get away with the 40 up to 40 to 45 millimeter mercury. So basically keep a dictum up to 40 to 45 millimeter mercury, you can go safely without any problem. 50 to 60 pressure is there, you can still go with regional anesthesia, but if preferably epidural anesthesia, because you have some time to manage. Beyond 70 PA pressure, please don't use any regional anesthesia because RV is compromised, lungs are compromised, and that can give you a trouble later.
Okay. Anybody else has any questions? Or any comments?
Yeah. Kalpana, I want to request him, see some of the cardiologists, they always like day before yesterday, I had a patient with 20% ejection fraction. And then the cardiologist insisted on regional anesthesia. So I didn't wish to give him regional anesthesia, but just because it was written, I was forced to give. So I think the cardiologist also should be.
Absolutely, madam. I tell you, your point is very valid. So what my take-home message is, please see who has done the echo report and just talk to him prior to the surgery at all. Who has done the echo? Let's see, you have mentioned this, but chances of regional anesthesia related these problems are very high. So you should be aware, because cardiologists are no one to decide actually which anesthesia you should be given. Not a regional, not a neither regional, not a GA. It is like it is our specialty to decide this. So
very much.
That particular thing, like you have to finish the links between the surgeon, cardiologists, or physicians. Just convey all of them that why GA is preferable and not regional anesthesia. This can happen. So it is very important that you create a link between yourself and the one who has seen in the cardiac point of view and the surgeon, that this is what cardiologist has said, but this has a probability. You should be aware about it. At least we should mention that.
Madam Nayak, would you like to say something or any comments? I think before the Zoom decides to take off, because it was booked only till 12:30, Naman, I take this opportunity to thank you once again. And I think it was one of very beautiful lectures, very lucid. And as you can see, how the responses have asked me to upload this and send them a link for the same for future reference. So thank you once again, Naman. And we wish and hope that you come again and on some other topics and do teach us.
Yeah, but next time you will be sure to give me a small, lesser time. Because I'm
Thank you. I want to clap for you. It's a wonderful lecture.
This is a teaching kind of a platform, and I don't want to restrict a teacher by giving him restricted period of time. But however, you and me both know that after 90 minutes, everything goes supra tento. But nevertheless.
Next time, just say you have only 30 minutes. then it can go up to the 45 minutes. It's fine. Okay, thank you very much.
Well,
And
thanks
thank
a lot. Yeah. Bye
Good
bye.
day.
Bye everybody. Thank you for
Bye.
joining.
Bye, everybody. Thanks, Kalpana. Bye, madam. Madam, I think he has left.
Sanjita madam was also there, I see.
Yes. Even Prasanna.
Hello, I'm here.
Yes, ma'am.
Thank you very much. No, one of my neighbor's son getting chest pain, so I was just seeing his ECG. Sorry. Dr. Naman, thank you very much. Beautiful lecture. Excellent. Excellent. Very nice lecture.
Thank you.
Just for a few minutes, I was at the door.
Thank
Thanks
you.
a lot.
Thanks a lot.
Dr. Naman, Dr. Prasanna is also there.
Oh, hi, Prasanna. Dr. Prasanna, how are you doing?
I don't know whether he can hear us or not, but I can see him.
Okay.
Anyway.
Right. Okay.
Okay.
Thank you.
Bye-bye. Bye, everybody. Thank you.
Bye.
Bye. Thank you.